received yesterday. But before we do that, I'm going to turn it over to Commissioner Brad Turner to say a few words to get us started.
I know he's there. He's just maybe having trouble get connected for a moment.
Yeah, I think I should. Can you hear me now? I had lost my connection. I apologize. Good morning, everyone. Thank you again for joining us. Certainly appreciate everything that you're doing, and I appreciate the investment and the engagement that you've had with our department the last several weeks as we're working together to try to navigate this. Very much enjoyed the call last week. Thank you for the positive feedback I had shared with a few members of our executive team, that we had over 20 emails that were sent back into our department thanking us for answering some of those questions and very positive responses, but a lot of that was generated by you. So thank you for being engaged in this. The format today will be very similar. We're certainly going to do our best to answer the questions that you might have, making sure that we provide some clarity and some direction on where we are right now, but also where we hope to go. So we do have our full executive team here, as Kara had just mentioned, and we'll be happy to answer those questions. So again, thank you for participating, and I'm looking forward to a robust discussion. Thanks, Kara.
Excellent. Great. Thank you very much, Commissioner Turner. So the first question we got, and we actually got multiple questions wanting to know an update as to where we are on Appendix K, which we know that everybody is is very interested in what that's going to look like. So just to touch a little bit about it and kind of explain where we are right now, Deputy Commissioner Jordan Allen will start off with a little bit of an update on that. Thank you.
Yeah, thanks, Kara, and good morning, everybody. So we finalized, in fact, yesterday evening, what we anticipate is the draft that will be submitted to CMS, that pending any substantive changes, that should go in the next 24 or 48 hours. And as soon as we send it off, we'll post for the general community to be able to see what's in the document. I'm reticent, or I hesitate to comment on specifics, just to make sure that we finalize all the language in the document before we indicate in the affirmative. But I will say that a majority of the questions that have come in thus far have to do with the department accessing latitude to further relax restrictions, and that includes everything from hiring and training. And certainly we've already gone, I feel like, to fairly great lengths at this point to try to meet the demands of social isolation and social distancing guidelines that have been issued by the CDC and the state government at this point. So we have addressed each of those components in the current document. The rest of the questions have centered mainly on emergency funding or the availability of funding for provider agencies. And again, I can tell you that we have addressed that component in the Appendix K document. Unfortunately, I can't give you specifics relative to how that funding will work, or certainly amounts that have been included in the document until that document is in fact a final and on its way to CMS. Again, we hope and anticipate that that document goes out either today or tomorrow, and as soon as we are able to post, we'll do that. And then if we need to have another forum to go over what's in the document and how, from a policy standpoint, we may implement components of that document, then certainly we'll avail ourselves to do that. The only other thing that I'll add to this is that, as I indicated, I believe during our last session, and as most states have already, those that have submitted their Appendix K to CMS have already indicated, the department and TennCare collaboratively sought to gain latitude for any and all potentials. And I just want to underscore the fact that we hope we don't have to access all components of that document, but it seemed prudent to get that information or make that request in this waiver in anticipation that we might need it, as opposed to have to resubmit an amendment to the Appendix K thereafter. So rest assured that anything that we've received thus far, and then some additional things, have been included in that document. We're hoping It's final draft at this point, but as soon as we know more definitively, then we will communicate that to the greater provider community.
Wonderful. Thank you very much, Jordan. So we're going to start with some of the questions that were asked in the chat function, the chat box last week. And then there are several times where we had multiple questions that were really the same thing. And I'll do my best to kind of consolidate all of those questions to keep the spirit and make sure that the answer would be consistent on those. The first question we had was about employees and whether or not they qualify as healthcare providers for the exemption from paid emergency sick leave and paid emergency FMLA per the new definition issued by DOL. So that's a question that is actually would be answered by the Department of Labor. And what we have found is we found some great FAQs on the Department of Labor's website. I'm going to put that link in the chat function, and we'll direct you all to questions 55 and 56, which pretty much encompass the majority of what providers have been asking when they've been asking us about this question. So hopefully you all will be able to find that helpful. And in just a second, I'll put that in the chat box. Our next question is about providers who have staff that work for multiple agencies, and what happens when one person tests positive or supports a person who tests positive at one agency. How are all of those other provider agencies? Will they be notified? We have set up a process to do this. I'm going to have our Chief of Staff, Tania Yo, kind of discuss this process. And then I think Teresa Sloan, our General Counsel and Assistant Commissioner, will kind of walk through some further guidance that went out in a 10-Care memo earlier today. Tania.
Thank you, Kara, and good morning, everyone. We have developed an internal process that will allow us to notify additional providers of staff exposure. Some of you probably already received those calls. I made a few last week myself. So when a provider calls to report a positive case, the on-call investigator is going to ask for staff names, the staff who have been in that home. And we know the initial caller may not have all the staff names and so last four of the Social Security numbers, but we will follow up as necessary to obtain that information. And then once we receive that, we're cross-checking those names in Relias to identify the additional providers, and our regional nurses will be contacting additional providers to make them aware of the staff exposure.
Excellent. And Teresa, would you like to follow up with some words about the additional guidance issued in the memo that should be distributed to providers through the regions this morning if it hasn't already been distributed to you all?
Sure. If you look at the memo gives explicit guidance on what should be done with staff who have been exposed to a person who has tested positive. I'd just like to draw that to providers' attention. The on-call will also do that starting today. And what we will do is point to that section which asks you or tells you to put that staff on leave.
Okay, great. Thank you for that. We also had a question about telehealth and utilization of telehealth. Jordan or Dr. Davis, would you like to talk about what we're looking at there?
Sure, Bruce, if you want to go ahead and give an overview, and then if I can or need to, I'll fill in any blanks.
Yeah, so there are several layers of that with regard to telehealth. One is with your ordinary provider, that if they are offering a telehealth option, that is certainly a direction that you want to go. So you should contact your individual physician or other clinical provider to determine how you could use telehealth in those circumstances. We've also had a lot of movement with respect to emergency telehealth, specifically around an agency named StationMD. We had them on the Clinical Consultation Network a couple weeks ago. Dr. Matt Kaufman, who is their director, was on there. We also distributed a communication yesterday from DIDD related to how agencies could get that service in the short term. This service is really important, and we've got a later question about emergency rooms, but StationMD has a very good record of being able to limit ER visits. And so under this circumstance, it's really important that we're doing that, because that's a place where people can get exposed, and it's a risk not only to the person but also to your staff. So if we're able to minimize those types of visits to the ER, and I'm not saying necessary visits. Obviously, if it's a necessary visit, if it's an urgent situation that requires emergency room care, then you should go. But if not, we should be avoiding that. Another alternative that was mentioned is, instead of going to an emergency room for a particular type of treatment, to go to a specialist instead, where you're going to be exposed potentially to fewer people. We had that circumstance in one of our ICF homes recently, and that was a successful diversion from going to an ER where there are a lot of sick people. We gave instructions in that communication yesterday for agencies to be able to make a contract with Station MD. There is going to be an Appendix K benefit. I'm not exactly sure where that ended up, so Commissioner Allen may, Deputy Commissioner Allen may comment on that in just a moment. But ultimately, if that benefit, my understanding is that if that benefit comes to fruition, then, and that's approved by CMS, that you would be able to recoup money that you might have spent on arranging that service when that Appendix K is approved. But it's certainly something that I strongly encourage agencies to engage in.
Great. Thank you very much, Dr. Davis. Our next question is about PPE, and we got several questions about PPE. So let's talk a little bit about the PPE requests. One of the things we asked is, should those requests include individuals supported through ECF? How much should we be asking for? How should providers care for individuals if they do not have PPE because of the supply shortage? We are all aware that PPE, the demand is incredibly high and supply is incredibly low. And we've been working very hard with TEMA to try to help and acquire PPE. So I'm going to turn it over to Dr. Davis to talk a little bit about when it should be used, looking at the new CDC guidance on masks, and also some of the things that we're doing as far as acquiring PPE and distribution. So Dr. Davis, if you can talk about that.
Yeah, we sent out communication yesterday, and I wrote an article, a COVID response plan update regarding the use of homemade masks. And so this is a practice now that the CDC has recommended. They've recommended that people, whenever they're in public, wear a mask. What I have recommended for our community agencies is that when people are working within 6 feet of someone, so in other words, in a home, if a staff person is working within 6 feet of another staff member or 6 feet of the person supported, that it is wise for them to wear a cloth face covering under that circumstance. And in fact, I would make that a part of my COVID response plan for you agencies out there. They are protective. They're not as protective as surgical masks, but under a circumstance where a person is not yet suspected, not yet considered a person who may have COVID-19, we should not be using medical grade PPE under those circumstances. So we have been able to obtain a small quantity of PPE currently. It is not enough to do mentioned last week. So I had wanted to outfit every agency with a supply of PPE. They would be prepared in case they had a positive case. We're not able to distribute that much PPE. What we have, what we anticipate receiving, is enough to meet the current needs and emerging needs in a given week. And so that means we're going to have to be more reactive in how we distribute the PPE than I had originally hoped. So that means if you have a person who is either has a positive COVID case, in those cases, we are going to distribute a full complement of PPE at the levels that I spoke of last week. In cases where you have a pending, where someone's results are pending, we are going to distribute a week's worth of that equipment to you until we get a result. And if that result is positive, we're going to go ahead and supply you whatever else you need. And if that result is negative, then we will stop providing PPE under that circumstance. That is, that's subject to change. It also depends on availability of materials, and there's a possibility that we would exceed, the need would exceed what we have. And under those circumstances, we'll be communicating that with you. But that is the basic plan for the distribution of PPE. Right now, we expect to receive supplies today that will allow us to meet the needs of all of those cases that are currently either positive or pending results. And so if you are, I would suggest the agencies reach out to their regional offices. That's where we'll be distributing it from. So you can obtain that equipment.
All right. Thank you very much, Dr. David. I hope that kind of encapsulates a lot of what's been asked about PPE, some of the efforts that DIDD is trying to do, and really, the realization that we are one of many who are asking for the same, asking for items from the same stockpile. So we're working very hard on behalf of everyone to make sure that we can get what we can, but just understanding that supplies are very limited. The next question we have is about enabling technology. Many of you probably saw the memo or the guidance that we put out, I guess it was 2 days ago, in regards to the expansion of enabling technology and utilizing Appendix K. To do that, and the fact that we really see a huge benefit that offers some flexibility and can potentially save lives. We did get a provider question about that, wanting to know what specific circumstances or examples does DIDD see enabling technology being useful to providers, which obviously we've seen the life-changing benefits that have already occurred in our service delivery system when it comes to enabling technology. And I think all of those people could really talk about how it has really improved their lives. But in this specific circumstance, I think Deputy Commissioner Jordan Allen can provide some specifics about how this can really impact people and providers in a way that keeps them safe, keeps them healthy, and really minimizes some of the staffing burden. Jordan.
Sure, thanks, Kara. So as Kara just indicated, and as many of the providers on the phone have already experienced directly through the DIDD Enabling Technology pilot projects, there are a menu of services available and products available that can allow people to more independently be supported in home environments. The broadest example, I guess, would be remote supports, and then there are certainly several steps along the continuum between that and just sensor technology or emergency response technology. What the department has done is avail the opportunity for enabling technology to the entire provider community outside of the pilot projects that certainly limited involvement up until now. And these will be provided and funded through the waiver. We've broadened the definition of specialized medical equipment in order to cover the cost of the equipment and then the ongoing monitoring fees, if applicable to that person's specific situation. We have also put together suggested packages, understanding that there's a significant portion of the community that has yet to engage in enabling technology, and therefore, from an understanding perspective, we'll need to know the gamut of services and supports that might be available. We've developed suggested packages, and then we also have technology champions in each region who are available to anyone interested to walk through how those services may line up to provide for someone in the home and relieve some of the staffing burdens that we're seeing across the network right now. So obviously and intuitively, very directly, if remote supports can be put in place and with an emergency response system can decrease the need for direct staffing during these times, then certainly we want to make that available to any provider who's interested. So, the only other thing I would add to this is the fact that we're moving this over into the waiver environment and expediting the process by which providers can engage, which includes expediting an amended provider agreement to add specialized medical equipment to any provider who wishes to access it, and then also making billing available for these supports almost immediately. We also understand that our need to be able to consult with agencies through that process certainly becomes more important, and we're willing to do that. So I would encourage each agency to take a look at the attachments that were sent out. If you have any questions about how technology may be able to support your caseload, reach out to your regional technology champion. They can get a referral form to you, and then we can very quickly work into the process of helping you develop a strategy for your caseload.
Okay, great. Thank you very much, Deputy Commissioner Allen. Okay, now we have some time for some of the questions that are in the chat box. First of all, I do want to refer, Donna Goodacre mentioned in the chat box that people do need to read carefully the guidance, the CDC guidance on using masks and proper utilization and disposal of those masks. I think that Michelle Bagby did provide a link in the chat box to that CDC guidance and some of the steps one should take to make sure that information is getting in the hands of your DSPs when it comes to mask utilization. So thank you for that good reminder in the chat box. If you did not see it, we just want to make sure everyone is aware that the CDC does have some steps and there is some guidance when it comes to properly using masks in light of their new guidance. Our first question in the chat was, has it been considered to temporarily allow family members to work more than 40 hours a week to limit the staffing ratio? Jordan or Teresa, would you like to take this one?
Sure, I'll start, and then Teresa, obviously chime in if you miss the mark or you need to fill in any holes. So the department is seeking the latitude to lift the 40-hour restriction on family members providing service in the Appendix K document. I want to reiterate that that document is not finalized at this point, and so I mentioned these things with the caveat that I can't definitively say that has been included until, in fact, the submission goes to CMS. We certainly anticipate that will be included. What we're asking is that any specific instance where a request would come in that would lift that 40-hour restriction should come to the DIDD COVID mailbox. We will then send that referral to the applicable region, who will reach out to the person making the request. Our intent is to assure that the request is based on the need to alleviate a staffing crisis. So we have some agencies at this point who have either made the decision or don't have staff available to provide in-home supports. Generally, these are PA supports. Obviously, the department has moved to make available homebound services to any person who had day services on their cost plan as of the 13th of March. And so in some cases, the 40-hour limit on family members providing service interacts with homebound services also. What we want to make sure is that as we're lifting that allowance on a case-by-case basis, that it is COVID related, and certainly it's at the behest of the agency and their inability to provide direct staffing, and not simply at the request of the family when in fact staffing from the agency might be available. So right now, if you have an individual request, please send it into the DIDD COVID email. We will get that over to the appropriate region, and then we will have a regional representative reach out to the person making the request to work through the details.
Right, and Kara, this is Teresa. I would just clarify what Jordan had said, and just to kind of make it more succinct, is the fact that it will not be a blanket waiver of the 40 hours. It will be looked at on an individualized basis through the process Jordan described.
Great. Thank you very much. I'm looking through the chat box. One of the questions came to, are DSPs wearing gloves in residential settings when individuals are asymptomatic? Dr. Davis, I'm unaware of what the guidance, the CDC guidance is here, but perhaps you can answer it.
Yeah, I don't think there's any problem with DSPs wearing gloves in residential settings. Certainly, that is a preventive procedure for a host of different problems that you might experience. I'm not sure it's terribly protective unless you have other protective equipment on. Although, we're not suggesting that people do that in a circumstance where the individual does not have either a pending or positive test or suspected of having been exposed to someone with COVID. Nonetheless, I think it's a general practice in many agencies that that staff are wearing gloves, and that's not a bad practice.
Okay, and I'm I'm going through the questions on the chat function, and if anyone has them, please use the use the chat function. I see one right now that involves using technology for medication certification. Dr. Davis or Teresa, would you like to answer that question?
Go ahead, Teresa. I'll let you take that one.
Kara, could you restate the question?
It says DIDD considered using technology to allow supervisors with med certification to coach a non-certified person to administer routine medications.
Okay. Yes, I think we're in the process of considering that. We've gotten a lot of questions concerning this. We've been looking at a few different options, but that is definitely one of them. And hopefully we'll be able to give you a concrete answer in the next couple of days.
Okay, great. Thank you. Going through, we've had several questions about riding around, and it's important to note that currently under Executive Order number 22, people are advised to stay at home. Teresa, would you like to talk about the executive order portion of this, and then perhaps Jordan Allen, because the questions are about billing, can talk about the billing part of this. Teresa?
Sure, I'll try to talk about both parts, and then Jordan can correct me if I'm wrong regarding the billing. So the executive order, which everyone understands, basically wants people to be safe at home and stay there as much as possible. We shouldn't be driving around just to be driving around. If a provider feels that a person needs this for mental health issues, which is what I'm seeing in the chat box, then they can choose to do that. But they need to be prepared, because towns have started stopping people, to be able to explain that if they are stopped by someone well out. Then this should not be used for everyone. And again, it should be used when it's clearly for that purpose. Transportation is part of the residential component. You cannot, if you take someone out driving, you cannot bill for it as community participation. Not integrated. You're riding around with your staff. It will be part of the residential payment for that day and a component of residential, and not their day service. Jordan, do you want to add to that?
Nope, that got it.
Excellent. Good. I saw some debate about that in the chat. So I hope that answers. Yes.
I'm sorry to interrupt. I just wanted to mention here, though, that I do think it is very important to be addressing the mental health concerns of people with intellectual and developmental disabilities as we approach this situation that we're in right now. Obviously, we all know that it's a very unusual situation. It's stressful. And, it's also stressful for the person supported. I think a lot of times we think that they're just kind of having to adapt, but they might not understand everything associated with why we're having to do these things. And I think, working with people a lot on explaining to them the reason for these different requirements that we have right now is very, very important. And also trying to find ways to help them deal with the stress more effectively. And so, you know, I do recognize there are a lot of restrictions at this point, but you need to look for opportunities to, you know, it doesn't mean you can't go outside. You can go outside, you can take walk, you can be, you know, as long as you're not within 6 feet of people, that is an acceptable thing to be doing. And I know that in some of these cases, you're going to have to do these types of things to help people get through. You know, I don't have to list a whole lot of activities, but there are a lot of activities you can do in the home too, playing board games, you know, playing cards, doing, you know, other things that are active within the home that help people kind of occupy their mind and not dwell too much on everything that's going on right now. So I do have the great concern for people's mental health under the conditions that we're dealing with right now.
Thank you, Dr. Davis. Okay, going on through the chat questions. One of the questions is, has DIDD considered letting transitions move forward as long as COVID-19 precautions are implemented? Jordan, do you want to discuss this?
Sure. So obviously, we're limiting transitions at this point based on guidance and necessity of transition, but we have availed case-by-case review of transitions to occur. Dr. Davis and the clinical team certainly review components of the transition. I'll give you an example from our own direct service in the community homes. We had an individual needing to transition back into the homes after being out for a short duration of time, and the appropriate medical precautions and clearances were required previous to readmission. There would be a similar assumption for any community transition. So any transition request needs to come into the regional office, and we are reviewing those on a case-by-case basis. Obviously, if the transition is of emergent nature or it would impact the person negatively to not be able to transition, then we're going to avail the opportunity for that transition to occur, but with the appropriate medical precautions in place.
Okay, and Jordan, I think the next question is going to be for you too. It is about the guidance sent out regarding staff ratio requirements, and just asking for some clarification on levels 1 through 3 that states unsupervised time can occur during awake or overnight hours with emergency response procedures in place. The question is it safe to assume that staff would not be required to be awake overnight?
That's correct. As concurrent with the guidance that we issued, we have amended staffing ratios during this emergency period. The specific amendments are indicated in the document, but for persons level of need 1 through 3, we have allowed for staff to be asleep overnight if need be, and this is specifically in reaction to limited situations across the network now where we have a potential positive COVID case or persons exhibiting symptoms, and agencies are moving to limit the number of staff in and out of the home. So this, the staffing ratio guidance that we issued supports the ability to limit staff in the home by potentially allowing, you know, the staff to be switching off every 12 hours, for instance, between asleep and awake. Additionally, with an emergency response plan in place and potentially with the implementation of technology-based solutions, it certainly is possible that no staff at all would be necessary in the home. Obviously, we'll need proper consent from the conservators and people supported in that environment, but the department can both support the development of a plan that can effectuate that kind of staffing, and certainly we have made for allowance for periods of unsupervised time in all levels really, but very specifically targeted at levels 1 through 3.
Great. And once again, I'll also reiterate that many of the things that if we have sent out guidance, we are putting all of our open line, special editions of open line and that guidance on the COVID-19 web page. We are updating it daily as we send out new guidance and as we send out new things so that it can be a resource for everyone. So I would really encourage you all to go there. And if you have specific questions about anything you see, obviously you'll also find that COVID-19 inbox link there as well. So thank you very much, Deputy Commissioner Jordan Allen, for that. Our next I'm going to give to Deputy Commissioner Andy King. It is about the $1,200 stimulus checks. If they receive these checks, people supported receive these checks, will they be required to spend the money right away? It places them over that $2,000 limit, which, as we all know, is the limit for Medicare eligibility. Deputy Commissioner Kidd.
Thanks, Karen. That's a great question. We are researching that right now, trying to figure out who the individuals that we serve will be receiving that, and trying to figure out what we need to do with that so that there's not a need for us to go spend that money immediately. So we're still working on that, but we're going to have an answer for you shortly.
Excellent. Thank you. Looking through, I'll give a minute or two more for any other questions to come in. But one thing I do want to, I see here that Janet Schaus has supplied us is if you have not heard about the IDD Toolkit, it was developed in partnership with the Vanderbilt Kennedy Center, as well as former Deputy Commissioner Tom Cheatham, about how to help primary care physicians really understand the specific medical issues that sometimes people with disabilities have that they may not have seen previously in there or been trained on previous to that encounter. Apparently now on the IDD Toolkit, there is a coronavirus section with some helpful tools and resources to explain social distancing and why things are different now, specifically for people with IDD. So thank you, Janet, for providing us with that information. I think that's very useful information for people to know. With it, we have a question. It's more of a consideration, and would the department consider writing a letter to families to help us in assuring them that things are being done to take good care of people? I will say that we have received some outreach from other providers about potentially supplying providers with some kind of communication just to help families understand the situation going on right now, and we are definitely looking at that.
Hey, Kara, if I can just add, until the time at which we may or may not be issuing that letter, that they just need to. There's great letters that can be taken from offline and just adapted. I don't know if he's on this call. I think Phil Garner sent a really good one, or a link to a really good one in. I would just suggest that providers use that for now so that they do have something in hand.
Okay, thank you very much, Teresa. Let's see.
Hey, Kara.
The question, yes.
Sorry to interrupt. I just want to make a quick comment about direct support professionals, because I really want to emphasize how critically important they are in this situation that we're dealing with. And, so I gave an analogy yesterday that if I had this great organization, and I compare that to having a great stereo system with this goes back, this is a little bit of a dated reference, but if you go back to when you had a turntable and you had good Bose speakers, you had everything that you needed for that. It didn't matter what you had if you didn't have the diamond needle that touches the record. And so that diamond needle in this circumstance is the staff that we have out there that are working with people. One of the really critical things I want to mention about that is the importance of them following the social distancing and other preventive procedures, not only when they're at work, but when they're at home. That's part of the reason that we've really been trying to limit the number of staff that come into contact with somebody, because that staff member, we don't know who they may have contacted outside the outside of their work. And so it's really important to educate your staff. We've all been immersed in this. I don't know if everybody has been as completely immersed in this as many of us have. And so making them aware of the risks that are out there and the, making sure that it matters what they do when they go home is a critical piece of all of this.
Great. Thank you very much, Bruce, for adding that. So we're at 10:13, and we are only scheduled to go until 10:15 today because we know everyone's got a lot of important things to do right now. So I'm going to actually, before we sign off, turn it back over to Commissioner Turner just to give some final words. We really appreciate you all joining us on this. We hope that you find these helpful, and we plan on doing this again next week, same time, same place, WebEx. And like I said, I'll turn it over to Commissioner Turner just to give us a few wrap-up words.
Thank you, Karen. And again, thank you to everyone that has participated today, and certainly appreciate your questions, and hopefully the answers that we gave you help eliminate any of the anxiety around some of those questions. But also, as in my nature, I just want to encourage you as well. This is Easter week. We've got Good Friday coming up, and for me, it symbolizes just an entire spectrum of rebirth and renewal, and all things are being made new. And I want you to be encouraged about where we are right now as a department, where we are as partners in this mission together, and how important it is that we continue to focus on the individuals that we provide supports and services for, that we care about, because hope is contagious. And wherever you are right now, I want to make sure that all of us are being the kind of candle in the darkness that we need in whatever area of state we find ourselves in, because it's that important right now. We're sensitive to what you're doing. We're sensitive in trying to make sure that we're giving you the right responses and the right answers where you feel confident and comfortable in doing your job. And while we might not have all of the answers right away, we're certainly committed to trying to get you the right answers when they become available to us as well. So thank you again for what you're doing. I just want to drive that point home that we can't do it without you. I'm grateful for your partnership. I want you to be encouraged, because even though we are going through a storm right now, as the governor mentions, this will pass. And at the end of every storm, there's always a rainbow. So keep your focus on that. Keep your hope on that during Good Friday and Easter week. And we will talk to you guys next week. Thanks, Kara.
All right. Thank you all very much for joining us today. Like I said, we'll do this again next Wednesday. Please submit questions if you have them in advance. We want to have good answers for you. And if we can find the answers, we will definitely do the best we can to do so. So with that, remember, next week when you join, please mute your phones immediately, and hope that you found this to be useful today. Thank you very much.